Just wait, sir.
Okay. Just let me know that whether you can see my face, laptop screen, because I can't tell whether anyone...
Sir, you're live.
Okay, so are they seeing my face or the slide? Can someone tell me whether your slide, sorry. I can't hear anything. I can hear echoing. Tell me whether my slides are visible. Perhaps someone can. Yeah, someone. That guy will. But show me your face. Where with your hand? My face or my. I can see someone's Bundy. Okay, I'm not hearing any here, which is a bit alarming. I'm happy, if you tell me you can see something, I'm happy to start. How about now? Someone speak back? I was speaking to someone in the control room without any difficulty.
You are audible.
Ah, fantastic. Fantastic. Which are you seeing? You see slides or my... Someone just told me I was audible. That person just... We can see your slides or we can see your face, and then I know which one...
We can't see the slides. We can't see the slides. Can you please put the slides?
Okay, brilliant. Sorry, let me just tell me, good, that same person, whoever you are, the person was, how about that? Someone feedback that slides are visible?
Yes, now we can see your slides.
Fantastic, thank you so much. I'm so sorry to have delayed 500 people, interventionists. In that time you could have 500 cents in, and so it's very disappointing for you. I'm so sorry. I'm very happy and delighted to be presenting a presentation about renal denervation for resistant hypertension here in London. I'll start with a case, a patient called W, who had uncontrollable hypertension. She'd been extensively reviewed around the United Kingdom at a tertiary centre near her, and then at national specialist centres where they did extensive investigations to exclude secondary cases of hypertension. They looked for renal artery stenosis, congenital causes, malignancy, all negative, and she had tests including normal renal function with no proteinuria, negative CT and magnetic resonance, and renal vein sampling, which was non-diagnostic. She had progressive worsening of hypertension over the 20-year career of blood pressure that she had. And in the last 18 months, she had blood pressure which remained elevated above 130 millimeters of mercury, very and you and I as interventionists think that. And there were episodes where it went above 300 millimeters of mercury. For 6 months, had symptoms, signs of heart failure and moderate to severe LV impairment. She had a marked decrease in exercise capacity, 3 inpatient admissions, and 1 stay in intensive care therapy. And here is her medical regime. Now, you and I, interventionists, you probably have 1 or 2 favorite antihypertensive drugs, and we have a vague idea as to what the other classes are. This is a shocking litany of medications at quite astonishing doses. Diltiazem and verapamil and beta blockers at supramaximal doses. And despite that, her blood pressure was way out of control, 250 to 300. Well, her doctors recognized this new therapy, which I'm here to talk to you about, and referred her to us to undergo this procedure. And let me just tell you what it was that her doctors had seen. This was the pioneering work of Henry Crum, Marcus Schleich, and Murray Esler, Asia in Australia, who did a proof of concept study and then did an endpoint study measuring blood pressure. And this is the result that they showed, that they were able, by renal denervation, to drop blood pressure by 32 millimeters systolic and 12 millimeters diastolic, when the control arm, this is a very well-conducted study, showed no change over 6 months. And so this is an astonishing 33 by 11 drop in blood pressure. This is not available by any drug on earth. I think you'll all agree. And so here I am as an internist talking to probably each of you have done 10 times more angioplasty than I have. So I'm very sorry to be teaching suck eggs, but here is the system. Now, there is only one catheter, standard catheter used, specially designed by profile, RF energy, at a low level and control, so that it automatically delivers the right amount of and cuts off the radiofrequency at the end of the tube administration or earlier if necessary for safety reasons. So this is how you do the procedure. Now you put the catheter into the groin in the normal way through a sheath, and there's a special sheath you use to access the renal arteries, a special guide catheter. Some of you are familiar with those. I wasn't, but it was very, very straightforward to learn how to use. And then you've got to restrain yourself. My colleague Justin Davis, who leads our program in Imperial College, actually has a nurse whose main job is to stop him keep pushing the catheter up to the heart, because that's his reflex. So he restrains himself to stop at the kidney and then take a picture of the renal artery. And then what we do is pass the denervation catheter into the renal artery to the furthest point before it bifurcates. Some vessels bifurcate early, and in that case you can use the large branch, as long as the branch is more than 4 millimeters. When an artery is very small, then we don't advise doing denervation in very small arteries. And what we do then is apply radiofrequency energy at that point, and that radiofrequency energy runs for 2 minutes. And the purpose of that is to capture the renal nerves which are running on the surface of the renal artery. They're wrapped around. So what we do is we apply energy for 2 minutes at one point. The device stops automatically, very, very. Then you pull the catheter back about 5 millimeters and then twist it 60 degrees so you capture a different point in the wall, and so that your two lesions aren't touching each other. And then you progressively come back and cover the length of the renal artery, 4 to 6 lesions, and you capture all of these renal nerves and denervate. Now, how does this work? Quite totally different from what it is that we do for the rest of our day-to-day practice. Well, I tried to show you on the autonomic nervous system, this is my favorite text from cardiology. But there's a problem. There's two problems with this diagram, which I use with medical students all the time until now. The first thing is that it assumes that all the signals are going outward from the brain to the other organs. The autonomic nervous system is controlling the other. The second problem is no kidney. I had to draw the kidney in by hand, and it's heart. That's how you know it's cardiology text. Heart, no kidney. Because the real message of renal denervation is it's about nerves that go to the particular nerves from the kidney. The signal is going back. Kidney is like a little endocrine synopsis in there, sending signals in patients with blood pressure to help tell the brain raise blood pressure. And as an aside, I'll tell you, your patient is interested to know that this is a little microcosm on with this reverse information from the kidney to the brain is very much like renal denervation itself. Because as you know, most new techniques start in America, travel to Europe, or sometimes other countries. But renal denervation is different. It actually started in Asia. The originators were people in Australia, Murray Esler, and then it spread to Europe. Finally, we'll go to America. So I do this to wind people up, so I point this out. Anyway, back to the real story. So the signals that are coming back from the brain are very important. They contribute to the brain raising sympathetic nerve activity. And if you watch people over time, sympathetic nerve activity period of months, progressively. Within 1 month, it's about a third down, and at 12 months, it's 2/3 down. This is data from Australia, the pioneers. And this also shows up in the norepinephrine spillover. Everything shows massive reductions in sympathetic overdrive. And this exemplifies the fact that the kidneys are the source of the driving force for sympathetic outflow in so many disease patients. And what you see is a fall in blood pressure. This is data across many, many patients, or Sievert in Europe, showing that the systolic blood pressure, unlike any tablet, as you know, most tablets have an initial drop in blood pressure and then it goes back up because the patients stop taking them. They may come up with silly excuses or they just stop taking them. Well, this blood pressure continues to drop for up to 24 months. So you admit the patient, you make sure they're carefully reviewed to make sure they're taking the tablets. You get reviewed by an anaesthetist because you need to make sure that they are adequately receiving analgesia during the procedure because it is uncomfortable, it's painful. And so we have a dedicated anaesthetist in some cases, but at other times Justin quite likes to use morphine and midazolam, and I won't teach you how to do it, you'll have your own way of doing it, but you must have adequate analgesia for the procedure. And carefully check that they have had tests for secondary hypertension, and that has been excluded. The procedure makes sure the blood pressure isn't too ragingly high during the case, and I'm showing you this is what we do for our very vulnerable patients. People actually have heart failure having these as part of a research project. And we managed to do this very safely. The experience in hypertension is that the rate of complications is very low, is less than 1 in 500 complication rate, and we can discuss what they are afterwards. Our particular patient was well controlled with anesthesia during the procedure. Her medications were temporarily reduced because she had a very rapid fall in blood pressure from 250 to 150. And then we discharged her home with a blood pressure of 200, gradually reintroduced the tablets, and she felt better. Her blood pressure was lower. She had symptomatic relief and increase in exercise tolerance. And now, at 4 months post-procedure, her blood pressure, which had been 250 to 280, is now 200 to 205. It's hardly normal, and she's still on the entire text of cardiovascular pharmacology, but it's a lot better. Let me tell you, if I've got a couple of minutes, I'm sorry, starting was a bit slow. Let me tell you the 2 great challenges you're going to have as interventional cardiologists. Number 1 is the biggest challenge. People will not refer these patients to have the procedure. And that's the experience from my colleagues in Central Europe. And the reason is this. They believe that the patients will stop coming to them because their waiting rooms will be empty and they will lose their income. So the advice I would give to my colleagues in India is the first thing you must do is after you do the procedure, you must refer the patient back to the referrer. And if you do not, you will never get another referral again, and your opportunity to cure this disease will evaporate. The second challenge you'll face is that people think that, why do we need to do this? We are close enough to target most of the time with tablets. Well, as you know, if you ask people, just as you ask people, most people think they're above average drivers. If you ask people, most people think they have very low rate of resistant hypertension. But in fact, blood pressure out of control, outside target, despite multiple tablets, is very common. 20, 25, 30% of the hypertensive population. And this is why we mustn't accept being close enough to the target. That's not good enough, and let me show you why. I don't know if you in India do the same as we do in the UK and have these charts called the score charts to try and work out people's cardiovascular risk for various reasons, and you put their cholesterol in and blood pressure in. And unfortunately, I can't hear you back, so I can't. What I would like to do, which is to ask you, what happens when someone's blood pressure is 30, 40 millimeters higher? Please all look at this chart, which is risk of cardiovascular events, and ask yourself, if it goes up, what happens to your risk? I think most of you in your head can see that it doubles your risk. Being 2 rows up on this chart doubles your risk of stroke and heart attack and death. And that's exactly the effect, that is bigger than the effect that you get from smoking. And so that's why I say, people say close enough is good enough. You may as well tell the patient to take up smoking, because it's just as bad being careless over that level of blood pressure. So just to conclude, I'd summarize by saying I've introduced to you the concept of renal denervation, a very, very simple procedure, which has demonstrated, which involves putting a catheter into the renal artery and using controlled radioablation to inactivate the renal Chernobyl of nerves sending signals into the brain and raising blood pressure. And it is a very simple protocol which you can pick up in half a day and be coached how to do that. Very simple. And you can expect a massive blood pressure reduction, 2 or 3 times larger than that of any single tablet, and it seems to be long-lasting. And for those people who doubt this and think it doesn't matter to be that degree lower in blood pressure, all you have to do is remind them the colossal effect of on cardiovascular risk of this level of decrease of blood pressure. Thank you very much. Now, I'm going to try and convert. By all means, I'm open to questions. Carry on asking even if you haven't got my face yet.
Thank you, Dr. Francis, for your excellent talk, and you make this RDN very simple. I think what I can understand, this is a very beneficial tool for primary idiopathic hypertension, excluding the secondary hypertension. And we are waiting, this technology should come in India. And what you mentioned, this should be treated from distal to proximal side. What franch, it is compatible, this catheter?
When you say compatible, can you clarify what you're asking?
7 French.
Oh, yes. It's a standard with 7 sheath and very, very standard. So the sheath you put into the leg is a completely normal sheath. When the company gives you the thing, it seems to be a long list of things, but they just have very complicated names, very simple things, like the 3-way tap, and you know the Y connector that an interventional, when you do an interventional procedure, they call it something different. So we thought it was going to be really difficult, but it turned out to be extremely simple. The sheath is a normal sheath. A guide catheter, the renal artery, is a special guide, which is just short, because obviously it stops to get stops at the renal artery. So the consumable is guide catheter to get a artery, the Simplicity catheter, which is quite expensive, and then there's the hardware, which is a special box that delivers the electric energy to the right duration, doesn't give it too long, and ensures it's given safely.
How much energy do you deliver, and how long, and how do you monitor them?
I'm sorry, yes.
How much?
The energy delivered is very low. It's about 50 times less than what people give for atrial fibrillation ablation. And the duration scheduled to minutes. So it's a very, I suggest taking a friend who is very in procedure, because it gives you something to do for 2 minutes. And my colleague just often found we ran out of after about 2 ablations. It goes for about 2 minutes, and then the machine stops if it finds that it's reached the endpoint earlier.
And how do you monitor the success of the procedure on table?
Absolutely right. Now, we got very excited about monitoring physiology. Got very excited about measuring heart rate variability, blood pressure variability, and online heart rate. Set up all the equipment. It turned out to be the world's biggest idea. Because when you put someone onto a table on a cath lab and you start ablating the renal arteries, it's extremely painful. And so the pain put the blood pressure up. And of course, you don't really do that. You anesthetize them with morphine and midazolam, or have general anesthesia with propofol. And all of those things completely disrupt anything you're going to measure. You can't measure a physiological, and you can't, the signals that you're trying to interrupt, so subtle, so fine, and the tiniest muscle artifact, which is all the time, completely swamps it. So it's not possible to detect that you've made a change physiologically, and you just have to take it on trust that you've been around formed the helix dot.
What I can understand, this is the simple outdoor procedure. Is there any radial experience of this procedure?
Not for me. I'm from the earlier generation. And when we first wanted to cardiac catheter around the body and a big bounding vessel, it was in the leg. And that anatomy has not changed. And so I personally do all my caths from the groin. However, I have colleagues in Europe who do try and do it from the arm, but the problem is the catheter length right, is theoretically possible, but I have no experience.
Anyone in the audience who would like to contribute? Or?
I'm so sorry, I might catch that question if someone's asking me.
What is the cost of the procedure?
What is the cost of the procedure? The cost. This is something, in terms of the cost, you have to ask the local representative, but I can give you in short, it's very expensive. It's more expensive than stenting. It's more expensive than a stent, and the catheters are expensive and they are consumable, and they're separate catheters for each patient. But we have to balance this against the fact that, for example, our patient is being admitted to intensive care because of a blood pressure of 300, had pulmonary edema, and was at the point of death. So the expense needs to be balanced against alternative.
How is the radio frequency current use different from the one which we use for radio frequency ablation for arrhythmias, as far as the catheter and the machinery goes?
Yeah, so in terms of the energy, it's about 50 times less. It's a very, very low power. And in terms of the machinery, you have to use the machinery that comes with the device, because the arteries are extremely sensitive. And I'm going to tell you something a little bit off-label, off-topic, off-message. But there is a guy in Europe contacted my colleague Davis to say that he tried to do this with an ablation catheter, AF ablation, and it didn't work, and it gave artery stenosis. I'm not going to tell you who that guy is, because you need to deliver a very, very dose of energy. And the whole concept of the catheter, that it deliberately limits the amount of energy that it gives, very small dose, and it monitors and impedance, and it ensures the temperature rises, but it doesn't rise too high, ensures the impedance falls. Because all of these are markers that the innovation therapy is sitting correctly on the surface of the artery and is not causing thrombosis and not blocking up the artery.
Thank you, Dr. Francis. You gave an excellent talk about this RDN, and give him a big hand, and we are waiting. This technology should come to India. Give him a big hand.
It'll come to you on the way from Australia to Germany, and you'll get it 6 months before the Americans. Don't worry.
Thank you, thank you.
We'll go to the next round by Dr. Fazil Malik on regulating balloons, the evidence.